Welcome, ladies.
Hello.
Thank you for being here. We know each other. Some of us have just met today, but collaboratively, we've been working alongside each other with the same purpose of working with kids and newborns with TOTS. And what is TOTS? Tethered oral tissues. And so when this opportunity arose, I was thinking, what's the best use of space and time today? And I thought no better thing to discuss than ties, TOTS, and you guys being professionals dealing with the same thing. What a great roundtable experience to help people learn more about it, understand it, and I think we're the best people to help with that. So thank you for being here.
Thank you.
Thank you.
Before we dig in, let's do some intros. And so Emily, kick it off.
I'm Emily Hussey. I am a speech-language pathologist and a certified lactation counselor. I'm the owner and founder of Eats+Speaks. We have a location in Byron and also a small location that services infants in Rockford. I've been practicing for nearly 14 years and been in private practice for about 6. Came into the world of myofunctional therapy, airway, ties, because of my children after digging and having sleep issues with my toddlers. And then really that's just been a massive catalyst. And it kind of opened my eyes into how I can treat my patients more holistically, thinking back to the patients and students that I served in the schools and how I didn't really feel like I did them justice. And then I found other areas within my field that I felt like really could impact. So I started with older kids initially when I was treating, and I just gradually trickled down to the babies because as I continue to do more work, I realized that those patients that are older, they often have difficulties with things when they're early as infants. So that's kind of my niche right now personally, professionally is infants, but our practice services pediatrics throughout the lifespan and in adults with myofunctional therapy as well.
Awesome. Kristen, tell us about you.
I am Dr. Kristen Beversdorf Safransky. I am a dentist in Mendota, Illinois at Westside Family Dentistry. I kind of stumbled into this world by accident. And once you start digging and it just keeps going and exploding, and I never realized what I was getting myself into and how interdisciplinary it actually is. I couldn't do it without a team. My part in this is a little part, but it's a significant part, and couldn't do it without you.
Yeah. Oh, I would say you're a big part of it.
Yeah. We're
not doing releases.
I will not be using a laser. No, thank you.
No, definitely not. And then lastly, I'm Dr. Christine Leonard, and I am a pediatric and perinatal chiropractor in Rockford, Illinois. Born and raised, I own and operate Healing Path of Rockford for the last 9 years, coming up on 9 years. Mm-hmm. And so we are family-focused chiropractic clinic, and we also offer a variety of holistic services from chiropractic to acupuncture, nutritional services, and we love the babies. We love the babies. And so similarly, it's something where, it's a mindset of being more proactive than reactive. And when we start to notice our children being able to communicate things with us, like through speech and talking, we realize that maybe some of the challenges that they're having as older kids, teens, maybe some of that started really early on. And so, I love just hanging out with newborns and holding them and doing all the things, but there is a large need. And I think maybe some of those challenges don't get properly addressed because they can't communicate to us what's going on outside of functional cues, right? And so there's just been a lot of development in the world of ties. I think they've probably always been there, but the importance and how it's actually affecting the body, I think has had a deeper dive in the last 5+ years that there needs to be more providers giving the information out there and not dismissing it maybe as it once was. And so let's talk about kind of, Emily, how you and I crossed paths. It was probably about 3 years ago. When did your clinic open?
So my practice opened in 2019.
19, yeah. So, okay, yeah. And so then probably 3 years ago, and I was seeing in my practice a lot of newborns and toddlers with challenges that made me start thinking there might be some tie or oral dysfunction happening. Now, staying within my scope, I love collaborating with other professionals. And so I had already been working with an IBCLC. And Emily, when your clinic came about, you were offering different therapies and techniques that I think are so valuable and maybe misunderstood too. Like if you say myofunctional therapy, I don't know that someone's going to be able to give a really good idea of what that is. So we'll learn more about that today. But then again, collaborating is just so huge, right? The betterment of the patient, no matter the age, the more eyes you have on it, working towards the improvement of that person just betters the outcome and betters the trust, right? And so there's just a lot of differing opinions from people. And while not everyone might share the same opinion, it's still important to have them so people can make informed decisions, right? So then my personal experience, as a parent, I had my kiddo 2022, so 2.5 years ago. I had already been versed in developing resources, and I was informed on what ties can do and affect, and I knew my girl was tied when I had her. She had a shallow latch. She was gassy, refluxy, blistering on the lip. It felt like 1,000 knives going into my breast when she was breastfeeding. And it was a challenge and it was stressful. I was a new mom and I wanted that connection with her, but we were having those challenges. And so, at that time she was getting adjusted. She was seeing IBCLC, which for those of you that don't know, is an international board certified lactation consultant. And we were seeing Emily at Eats+Speaks. And we had set up an appointment with a pediatric dentist to have a revision done. She had a class 4 tongue tie and class 3 lip ties. And so we'll learn more about the classes, but those were the highest level and with the most severity. And she had the functional deficits with it too. And so, we went and we had the revision done. I think she was like 3 or 4 weeks old. And again, that's scary too, because as much as I know, I'm not usually there with the dentist doing the revisions, and you hear laser and
Different when it's your kid.
100%. I mean, it's intimidating. And we did the revision, and things didn't change right away. I was able to put her on the breast, and it felt no more needles, no more knives, which was great. But there were still other challenges, and so it was something that I think everybody wants, like instant gratification. That's just not how it works, right? We need a team and we need patience, and healing is a journey. And we've gotten through the journey, and, those things started to dissipate in their own time. And I was just happy to have the support. When I had her in the hospital, they do have lactation consultants there. And unfortunately, they were not helpful, right? And so I didn't know how to put her on the boob. I didn't know that there were different feeding positions. They couldn't really explain why I was feeling the way that I was feeling, and I just needed more help. And I was able to find that community for help, and it served my family better, and that's just kind of what I'm trying to put forward, and I know that you both do the same as well. So today, that's what I want to address. Parents need information. They need answers. This is a common thing that is affecting more people, and it's talked about more. And unfortunately, there's outdated ways of handling TOTS anymore, and there's new research on better ways to go about it. And so I wanted us to sit down, collab, and talk about it, and just kind of debunk some stuff and just answer questions of things that parents might be wondering. Yeah. Cool. All right. So let's kick it off with, what is TOTS? Doctor, let's take it out with you.
So tethered oral tissues, there's several of them in the mouth. You can have one on your lip, holding your lip down, so you won't be able to get that good flange when you're feeding, not just with breast, but also with bottle. And people don't understand, just because you can't breastfeed doesn't mean you can automatically bottle feed. It doesn't. There's some same mechanics there. You can also have a tongue tie. So there's a little string underneath your tongue, and there can be different severities of it that can hold down the tongue so you can't get that good peristaltic wave and good suction and control. You can also have cheek ties or buccal ties, and I also look for those. I don't release those too often, but I do check for them. And so there's different types of ties, there's severities of ties, and there's also different classification systems. So that's where some of the research can get a little fuzzy too about classification systems. So I basically you can look at it, but you have to go also based off of symptoms. Because even though it looks like a tie, a baby can be compensating, and the breast breastfeed beautifully. But then again, if you look under the tongue, you don't see anything there, but they can still have all of these symptoms. And then you go to release something and things get better. So it's kind of crazy how that, just because it looks like a tie doesn't mean it needs to be released. You have to go based off of everyone's symptoms and the function.
Yep. What about the history? Like and that was one of the questions that I had asked too when I was getting it revised. I was like, where is this coming from? Where is it starting? And there's different theories on the why that it happens in the first place. Can you speak to that at all?
Yeah, so back in like the 16th century, there's pictures from books that have midwives growing their fingernails so long so they can just release a tie right then and there. That's crazy. I do not use my fingernails to release any babies.
Appreciate it. So glad.
And then back around the mid-20th century, it became popular to do frenectomies again. But then formula came around in the 60s, 70s. And so breastfeeding kind of went, not away, but about 75% of people, they thought formula was better. So they bottle fed. And now we're having a shift again towards breastfeeding's better. And so there's, like you mentioned, a lot of different studies. And a lot of the studies, one, they don't mention the technique they do, or there's no aftercare mentioned. So they can get tied back down, or they don't get as good as results as working with a team, and that'll skew your results. So it's good to look at studies and see kind of the technique they used, and also if they did pre or post care, because when you do it that way, we're having really great results. There's also old theories that, they'll just fall when there's a toddler, and then it'll just tear. Yeah.
No, providers still say that. That happened last week. And I'm just like, we're banking on your kid falling?
Yeah.
And tearing tissue? Like, what?
Yeah, that's if they fall in the right exact spot.
Right.
You know, my son just missed it just by a hair, and you're like, why couldn't that be just a little bit farther over?
It's just, and I mean, while it happens, I don't know that that's necessarily like what we should bank on, right?
Exactly.
That's kind of being more to each their own, I guess.
Yeah, I prefer more controlled setting. There's less blood, when you're walking around the living room and tears, parents are freaking out.
Teeth are intact from no fall.
Mm-hmm. To tear your tongue, that's pretty tricky unless you had something in your mouth to tear it. Yeah.
Well, and then there's genetic changes too, was one of the theories as well. And so MTHFR, and so methyl tetrahydrofolate reductase is a genetic mutation, and it affects somewhere between 40 and 60% of the population. It's the inability to convert folic acid into the bioavailable form, which is methylfolate. What do all OBs recommend to their pregnant patients?
Folic acid.
Mm-hmm. And, it's not just in supplements and prenatals, it's in so much food. So even if you're having a methylated vitamin, all of the enriched white pastas, white rices, I mean, it's truly hard to get away from because it's cheap and synthetic. But if there is a connection to this, a lot of dietary and environmental changes change the generations to come, right? Well, why didn't we see it then? Well, the water and food supply was different then, et cetera. But it's something that even the MTHFR mutation affects a lot of different things, but in particular, it also affects this for today's topics. And so if avoiding those things, and that's before you even start conceiving, right? And so I won't go on that trail, but it's, epigenetics is really important related to conception, and you can change the makeup of the cell. So if you're avoiding these things and having proper diet, nutrition, et cetera, before conception, it really can set the stage for a lot of changes for the child as well.
I'm glad you brought this up, just because I was looking at some prenatal vitamins, and the percentage of folate or folic acid in them is like 1,000%. And that's just wild to me.
Well, and what OBs don't know, I don't think they're testing for MTHFR in their pregnant populations. And so if they are taking folic acid and you fall into that 40 to 60%, I mean, the whole point of folic acid, the intention is good. It's to prevent neural defects in utero. But if you're part of that 40 to 60%, you're getting no benefit from it at all. Right. You're creating more issues for yourself as the parent, but then potentially for the child as well. And so, and then that's just being mindful too and knowing this stuff. But if the info is not out there or readily available or in understandable terms, it makes it hard to avoid or to know what to do better. A lot of people are, what my doctor says goes. But there is a kickback anymore where people are doing their homework and doing their research. And even if it's on Google, that's okay. You know, advocating for themselves and making the best decision for them where they feel part of the decision making too is really important. So, okay, so what can TOTS or ties affect? What do we see in our clinics? Symptoms, functional changes? Who wants to start?
I can go. So functionally, what I see, obviously the biggies of, pain at the breast, difficulty emptying the breast. Mom has maybe a history of mastitis or clogged ducts. Baby cannot stay on the breast, so feeds are incredibly exhausting because baby's on and off the breast often. Same with the bottle. Inefficient feed. So when we think about the baby's coughing, gagging. You often hear a clicking sound because they're losing that suction. And then it goes into some of that those GI things. So we're not getting a good effective latch, whether it be tongue and lips being the culprit. But then we're taking in air throughout the process. So that's filling our belly up. Then we have increased chances for either reflux, actual spit up, or silent reflux. And then a lot of these babies kind of go into these short sleep patterns where then their breathing is also labored as well. We see babies, I'm obviously a speech therapist and a lactation counselor, but I am getting better at visualizing different postural issues with babies. So a lot of our babies come in and they're kind of like this C-shaped pattern. Their head is always tilted to one side. Tummy time is really difficult for them. Or the opposite of we're 2 weeks old and we're rolling already consistently, which that's obviously not a positive. And a lot of times it's seen as a positive, as like my baby's really strong. They're rolling at 2 weeks or 3 weeks, and it's actually a tension pattern. So those are the biggie functional things in infants that we see pretty consistently. And so it's teasing out and working through that aerophagia, but there can be other reasons, and that's why I'm a big proponent of that functional assessment, because a baby can come in and have ties and be refluxing, but it's actually, we get rid of the aerophagia, but it's actually something in mom's diet. So there's lots of different reasons for things, and I always want people to have a good lay of the whole land before we start heading into surgery and hoping for something, because sometimes it can be something different. So yeah, I would say those are the biggest functional deficits that I see that are pretty consistent across the board.
And there's some overlap, I think, too, with the chiropractic. And so, again, when people, pediatric chiropractic isn't as popular as chiropractic just as a whole, being for headaches and back pain. Well, newborns don't have headaches and back pain. They're presenting with different cues. Torticollis, where we've got that head tilt one side to the other, and some degrees are more severe than others. The postural adaptations we see as well, whether it's shoulder height, scapula, all the way down to the toes. I mean, toe walking, the fascia in the mouth goes all the way down to the toes. And so, primitive reflexes can play a role in that as well if they haven't integrated at certain ages and contributing to toe walking or W sitting and things like that. It's just those tension patterns. But again, we see the reflux and we see the constipation, which is a big one too, with all of the air. Where we'll see improvements with some of these things that parents bring their kids in for, we will also see regressions, because I think once they hit a growth spurt, as little or big as it is, when that change is happening, the ties aren't changing, right? And so we'll see that regression happen in the symptoms that brought them in for care in the first place. And so it's really important to be assessing the body as a whole. And for our office, we don't function, or we don't focus on the symptoms. I mean, we're not ignoring them, but we know that there's some imbalance in the musculoskeletal system affecting the nervous system. And so when we can move the spine or move the cranial bones, we'll see releases in this tension, in the whole body tension. There's better tongue function, there's better oral function when everything is able to move. Cerebral spinal fluid going up and down the spine through those cranial sutures. It's one piece of the puzzle, though. Right. And so then we've tagged in nutrition along the way, because nutrition is just as important for newborns as it is for adults, right? They have that liquid gold breast milk for those breastfed babies, but even with formula fed babies, supplementing and getting in the right nutrients are really important too. So the body's firing on all cylinders and having the best ability to heal and start to change and adapt. That's the biggest thing, right? We need them to adapt. I would say that's a big common denominator with our professions is we're allowing the opportunity for their bodies to adjust, to get into a better environment, to be able to thrive, right?
Right.
So you probably get people on the coming in for the revision already, or are they coming in symptomatically saying what's going on? How does that work in your office?
So they'll call my office, and then either they're already referred there, or I say, let's go see a myofunctional therapist first. I want their opinion first to see if you can do positional changes or, some torticollis chiropractic work.
Yeah.
Try that first.
Yeah.
For sure.
Yeah. Let's see here.
And then as far as long term, I want the tongue resting on the palate.
Yeah.
That will kind of shape and guide where the teeth will go. So if all your muscles and everything are aligned, your jawbones are aligned, your teeth are going to come in straight. And that also goes with diet. Now we don't really need to chew our food at all. So we're seeing evolutionarily, our jawbones are getting smaller, impacted wisdom teeth. Now we're starting to see impacted second molars. And so that's a huge.
So when you say we don't have to chew at all anymore, what do you mean by that?
So like we used to have, eat a lot of nuts and chew our meat, off the bone, things like that.
Yeah. Now there's juicing and there's intermittent fasting. There's less availability for using the masticating muscles and jaw and doing those things. Yeah, that makes a ton
when
of
we're
sense.
not, eating raw veggies and meat, our kids are often choosing those heavily processed foods, and that's what's often just thrown at them. And when we don't use the soft tissues of the mouth, that impacts the bone growth. And we see that very frequently in our office. Patients who come in who are really picky, who are older patients, they're really picky. They also have a really weak jaw, and they're small, and their mouth is very small. So it just all kind of comes together.
Well, and I think too, a big thing with babies is pureeing food. We never did that.
I also don't like pouches.
Well, and just
They're
to
so
your point,
convenient, but
convenience is king, right?
Yeah.
And so it doesn't always equate to better longevity with health and
Right.
development and things like that. And we used, I don't remember who it was, but there was an app, and it was talking all about whole foods. So my little, however old she was, when she can hold, she was just gnawing on carrots. You know what I mean? And maybe it's just me being lazy as a mom and not wanting to smash up all the food. But I mean, it was baby led, and it was just what she wanted to do. And but nonetheless, even though we still had that diet for her and way of eating and chewing, we still had the challenges, that came with, and this was even post revision. And so, and that was months later. And so again, healing is a journey, and it takes time, and it takes knowledge and resources. So, so how this is important. So again, like when I first started, I said, we don't know how to define myofunctional therapy, right? And so how would our respective professions address, I don't know, how do we want to ask it? Ties or the symptoms? What does myofunctional therapy involve?
So when a patient is an infant and comes to see me, I am not doing myofunctional therapy with them as a baby. But what I do is I do feeding therapy with them and use principles of myofunctional therapy to do that. So that is one thing that I do want to address, because it can be a little tricky when we think about scope of who's doing myofunctional therapy. So true myofunctional therapy is with a child at the cognitive age of 4 and up who can volitionally do tasks. So a lot of times infant therapy that I do is considered, people will use that term myofunctional therapy, but it's not true myofunctional therapy because the baby isn't volitionally doing things. But I'm using concepts and things like trying to get the baby's tongue to rest up on the palate while we're doing it. So I do want to address that, in that the term that I would say when someone comes to see me, it is feeding therapy, lactation support, because I do lactation counseling as well. But that kind of addresses that. So what I'm looking at is I'm looking at the mechanics and the structures of the mouth. And then obviously I look at the body and refer out to whoever would best serve that patient. But I'm looking at the tongue's ability to extend, cup, lateralize, elevate in a very synchronous way. Okay. And I'm looking at the tension patterns. I'm looking at oral reflexes, and I'm looking at suck patterns as well. So those are the basic mechanics. And then I'm also looking at their breathing, and I'm looking at where that tongue is resting in the palate, because I want that I tell my staff and my team, like, long after someone leaves here, I want to impact their life. Like, I want their health to be impacted when they leave. I don't want to just fix this issue. And obviously I don't have a crystal ball, and we do have people that come back and say, this next challenge came up, and we support them through that. But we want to try to impact them long after they're gone. So I would say myofunctional therapy, oral motor therapy, feeding therapy in infants is basically like physical therapy for the mouth. We're strengthening, helping coordinate the muscles, pre-release, post-release, no release, to optimize the functional things. And we always look back to breast, bottle, solid feeding at that age.
Yeah, no, that's great. And how about your clinic? So with the respective professions, how do you guys address it? Usually it's with, after you've already kind of referred to other therapies, let's say that the revision is still going to be appropriate. What is the process like when they come to see you?
Sure. So we have the parents and someone come back. Usually it's the mom, but also sometimes it's the dad, sometimes it's a grandma. I like the parents to have someone there to support them, because I usually do the procedure same day as the consultation. And so it's nice to have, instead of a mom just sitting in the room by herself, like worrying about her baby, have someone to kind of hold her hand through the whole thing.
Oh, she's in there with you?
Oh, no, it's separate room. But
I was like, oh, cool.
No.
I tried to go back for mine, and he was like, nope.
No.
Come back for anyone else, but not your own.
Yep.
There was, yeah. So then I do a thorough exam looking at the structures, basically how tight they are, how flexible they are. The symptoms is what I really go off of. And of course, the referral from the report from, feeding therapist or chiropractor.
Yeah.
And then, and so then I kind of steal the baby away for about 10 minutes. It's a really quick and easy procedure on our end. So what I do is put a little numbing jelly on there, special for babies. And then we do take before and after pictures also of everything.
Those pictures are great. I really enjoy them, like the reports that I get too. And I think it's really helpful for the parents to see as well, like, because we don't know what we're looking at, right? We don't look in mouths for a living, and, especially if you have no background with dentistry or anything like that. And it's cool to see the before and the after pictures, absolutely. So that's really neat.
My favorite picture, though, is I do try to take a picture with the baby laser safety goggles on.
Is there any head left? I'm sure the goggles are big.
They actually make them for babies. So
really? Neat.
Yeah, sometimes they're cooperative, but other times, as soon as I lay them down and put them in the swaddle, they're crying.
Yeah. So, and I think that might be a fear that parents have too, especially because we can't go back into the room. Our minds probably go places that they shouldn't go.
Sure.
And while it's the longest 5 to 10 minutes of our life, what do you do to help console the baby during that time? Like, what is happening if they're swaddled, but what if there's still a lot of head movement or whatnot? Like, what does that look like to help tame the baby? Because I think our minds can go a little wild thinking about that.
Oh, sure. I have at least 2 dental assistants in the room with me to help take pictures and also to kind of hold the head still and everything, so there's no movement.
Gotcha. Is it a dark room? Is it a bright room? Like, what's the ambience in the room? I'm sure there's a lot of lighting, but nonetheless, is it what's kind of the atmosphere in that room like?
Sure. So I just use a plain old dental laboratory. So the one you get your teeth cleaned in, that's kind of the room I'm working in. I do use loupes, so magnified glasses, and I also have a headlight on there that's so bright.
Okay, so if that was coming at me, I'd probably be crying too.
Yeah, and it's funny you say that. So when I do my exam, I do it with the parents in that room and everything. And I say, they're not going to like me messing around and they're pulling on tissue that's tight. They're going to probably cry. But also my light is very bright, so they won't like that either.
Yeah, double whammy. So, well, we're going to get into a little bit more of the details, like with the laser and everything in a little bit. But I will speak on with the chiropractic, and so how and what our goal is when we have kids that are tied. And so I kind of alluded to it before, where we start to see those postural adaptations, but 9 times out of 10, if there is oral tension, there's going to be muscle skeletal tension. And so the goal being to release and balance. I think there's a big misconception with like how babies get adjusted. It's very different than how adults get adjusted. And, the TikToks don't help with videos and everything like that out there. So don't believe everything that you see. But it's a very gentle adjustment, whether it's to the cranium, whether it's to the cervical spine, or anywhere down into the spine, even into the pelvis, and putting specific motion into those joints, whether it's with a tool that we use, it's called an activator, or our hands, it's a sustained pressure with movement, and letting the baby pretty much guide how they're moving. That really does help facilitate movement of that joint. It releases everything. And with releasing the neck tension, orally, everything that's connected to it, or the nerves that innervate those areas, are able to calm down as well. When we enhance the spinal and cranial movement, it does help with patterns of sucking or feeding and things like that. And it's maybe a little harder to objectify in a chiropractic office, because we do have a larger scope as far as what we're trying to balance symptom-wise with people. And so it's not something where it's just working with
only the feeding or
exactly.
Right, yeah.
And so it's something, again, where we're collaborating. It's all for the betterment of it. But sometimes I think people miss the mark. Well, you're not a chiropractor that just works in mouths, so we're going to go here, we're going to go here. But it is all connected, and truly I've seen the benefit of it, with my own kiddo. And so it's something where there is a lot of overlap. But again, our specificities with our professions are what really helps to make the big piece of the puzzle, or the big pie, come together, if you will. And so, I love the overlap, and I love the collaboration. And pre-revision too. When we can take compensatory patterns out of the body prior to a revision, the healing potential is a lot higher. And so in post-revision too, it's something where I talk about ties a lot with parents if I suspect that there might be something going on. But again, staying within my scope, I'm giving Eats+Speaks, I'm giving my IBCLC and the resources to be able to evaluate it further. But I think a lot of families' journeys have started in my office and gone down that path. And while it's long, I can speak to it from a place because I've been there, right? And so I know how to get to the other side a little bit quicker, and with a little bit more success, if you will. And so the post-revision and pre-revision adjustments are, in my opinion, as important as the pre-exercises, post-exercises, and working on those things. Because what maybe people don't know is those ties can reattach, right? And those exercises sucked. I'm not going to lie. My daughter would scream at me. My husband would hold her and like this, and he'd make me do the exercises because his fingers are too big. But I just started doing them when she was asleep. It's just, for us, it worked easier, but they're tough, and the frequency of how often you're having to do them, which you'll speak to in a little bit too. But yeah, the adjustments I feel are a major point that maybe gets missed by parents as much, just because we're not specific just to the mouth. But
yeah, and I think clinically for me, I would prefer a baby have body work before, because it increases my chances of helping them. Yep. So I feel like they get better outcomes on what I'm doing. If we're tied and our jaw is tight, and I can't get that first initial wide gape to get to the breast, you can get released, but your jaw is still going to be tight. Yep. And I can't get that. If we can't get that wide gape, then it's going to impact the suck reflex and the peristalsis, and now we're in pain. And so I see better outcomes with patients when they do that body work before, to kind of release that tension and let the body do some healing before we go in. And it allows, I'm sure, release provider more to work with. They have maybe even more that maybe they could get a little deeper. I know infants can't go as deep as, older children and adults, but I think the outcomes on your end are substantially better too.
Well, and vice versa, the overlap when I have patients that are seeing you guys, I don't see those regressions I was referencing earlier as much when they do have those growth periods because the body is able to adapt with more ease to those changes and those developmental changes that they have as well. Okay, so big question. To revise or not to revise?
That is a $1 million question.
Hot topic, right? And again, with more information coming out about it, and I'm hearing more pediatricians saying, "Yeah, but it's fine. The baby is gaining weight." That is not the end all, be all.
I also heard it'll just stretch out.
Yeah,
It doesn't just stretch out.
Stretch out. They'll grow out of it. Babies don't have, they'll grow out of it. Babies don't have allergies. Babies don't have, plethora of things. And I always think back to like, we can have those comments on certain things, but we still haven't solved the problem. That's why the patient walked in the door in the first place. So we need to dig a little bit more. And the good news is there are solutions.
Yeah.
There are things that we can do.
I think talking to the right people, though, is important too, because while pediatricians are very relative and important, they have to deal with a lot of different symptoms. And when it comes to something so specific, I think it's important to find advice and information from someone that solely works in the area of the symptoms. So with TOTS, I'm not just going to go to my dentist. He's not a pediatric dentist. He looks in my size mouth, bigger size mouths. I want someone that's looking in that size of my child's mouth on a regular basis to see the changes and the different variations that can come at that age. And like I said earlier, there's a lot of outdated information too, and people still using, what do they use, scissors?
You can get a really nice release from scissors, but it's a little bit messier.
Yeah, and I just, and there's just smoother ways. But again, for someone that is not specializing or focusing specifically on that, they might not be up to date on the newer techniques or equipment and things like that. But so, yeah, when do we revise? What are we looking for that says, hey, this is going to be an appropriate procedure to do?
Yeah. I can touch on my end. So there's a lot of different factors that go into it, and it's different for every single family. So this one family could come in and have the same exact symptoms as this family, but this one's going to release and this one's not. And I think that's another key thing is outside of the other things that I mentioned about all the symptoms with baby, we're looking at mom. Does mom have any postpartum depression or anxiety? When does mom go back to work? Does mom have any support at home? We're looking at all of these different areas because the last thing I want to do is put someone through recommend or put someone through a release and then it reattach because we don't have the support. And now we've gone through all of this and we've backtracked. So, we really look into what the family is able and ready to do, but also for us, I make the call. That's why, depending upon the situation, assuming that mom is not in tremendous amounts of pain, I feel like that is a situation where when mom is in tremendous amount of pain and we're seeing structural deficits, functional deficits, that is one that I feel like is a little bit more urgent because mom's like, I don't know how much longer I can do this. And we might lose the entire breastfeeding relationship if we don't do something. So we need to get some chiro in there quickly. We need to. So those are situations that we might need to do something a little bit quicker. But I never feel like it's an emergency to go get a release. I think that's sometimes if we do it too quickly, then it doesn't always give us the best results either. So we're looking at a number of factors there. Generally speaking, I like to do a little bit of therapy to see if we can even make some improvements before we go. But what happens is usually we'll hit a wall. And whether they're either going to chiro and maybe they get adjusted, but then they're not keeping those adjustments. And it just keeps going back. And we get further and then it slides back again. And so when we maybe make progress and then regress or make progress and stall, that's usually a good indicator that a release, we've kind of just hit our limit with where we're going.
What type of time frame does that look like for somebody? Like how long is comfortable working with a family before, and maybe they haven't hit the wall yet? Like, what's the time?
So
Fair
generally
time.
speaking, I feel like most of it's like 2 to 4 weeks where we're like, if mom's like, you know what, I don't really want to do the release. I'll do it if I have to. But like, if we can try to avoid it, let's do that. I think depending upon the age of the patient, 2 to 4 weeks is a good framework. Now, I think it's much easier to release a baby before 12 to 15 weeks because I have a lot of oral reflexes I can still build off of. So these babies have a suck reflex still. They have that transverse reflex of the tongue. Once we hit that 12 to 15 week mark, that's when those reflexes start to integrate. And so then if I want to retrain that suck pattern, I need that baby to volitionally want to do that. And you can't talk any 15-week-olds into doing things. Yeah. So I think there's that sweet spot. Some babies integrate a little sooner. Some babies are born and they don't have a suck reflex, that's a topic for another day that I would love to talk to you all about. So that can make things difficult on that end. But what I tell families is it's never too late. It's never too late to support your family through something like this. Each stage just looks a little bit different. Yeah. And so, yeah, I would say to kind of summarize, we look at like support within the family. How is mom doing? If mom just went through a C-section or some traumatic birth, is she ready to be waking up and doing wound care management with a baby? And then also like that regression and like stalling of therapy, or you're seeing tension patterns that like baby is not turning their head. Yeah. We can't nurse well at the breast on the right side because we're not getting any movement in that neck.
So I have a question. Now, you had said earlier that you'll see tied kids, but functionally everything is fine, no compensation patterns, revision might not be appropriate. Now let's fast forward 7 years. They still have the ties, but now they've become symptomatic. No crystal ball. Right. So where's the difference between being proactive and being reactive? Because like you said, a 7-year-old's going to require far more intervention than releasing a tie and potentially avoiding anything that might come up. Nothing might come up, but something might come up.
Right. Yeah. That is $1 million question right there. I've gone through it. I have 3 children at my home, and each one of them is different, and we've done things differently with each one of them. And the one that was released at 8 weeks, we're still doing things to support her airway and early ortho for her and all these things. So I wish I could say like, get them released early and then it'll just be all perfect.
Is there a downside to doing that though? In the event that it's a relatively asymptomatic child, just to try to preclude any other?
I wouldn't say that there's a
things?
downside, but what I do say is it has to be worth it. Yeah. I tell the family, it has to be worth it for you to do this because I want to make sure that you're going to do the wound care. I want to make sure you're going to do the exercises. And so if it's not worth it to them, then it's probably not. I also feel like I've done this. I haven't probably seen a kid for a whole, like till they're a teen with this. So I've not been doing this long enough to say like, oh yes, like these patients of mine, they came back and they were great when they were teenagers or whatever. But what I do feel like I'm getting a better eye at is looking at the structure and be like, okay, you don't have any symptoms right now, or these symptoms we've resolved, but looking at the structure in the mouth, you're going to have issues. I'm predicting that the likelihood of you having issues with speech or feeding later on airway is probably high. It's going to catch up with you sooner than later.
And I think speech is a scary thing, right? There's a lot of kids requiring speech and motor intervention, and the PTs are backed up. I mean, it's a long wait. I have some families that have been waiting 6+ months to get into speech. And once these kids get into speech, I mean, it's wild how quickly they adapt and change. But now they've had all of these behavioral changes because maybe they can't communicate effectively. So now they're being misdiagnosed with maybe behavioral type of changes where it's just they're not being able to use their tongue or move their lips to be able to communicate what needs to be communicated. And so I think that's a major thing as well, where, my mindset is being just more proactive than
Right.
reactive. But again, it's a decision that every family has to make what's best for themselves, right?
Yep.
Any comments on revise or not to revise?
I always say the earlier the better. Although if it's a first-time mom or even a second-time mom, it's sometimes you don't get the help or realize there's help out there for what you need. They just think, oh, I just can't breastfeed, and then they just stop. And they don't realize there are resources out there to help them. Or sometimes they realize the resources are out there and the baby's 8 months old. You're like,
Yeah.
I wish you would have came to me, 4 months ago or, earlier, but we can still help older babies. I don't release babies over a year. And then once they get set for anesthetic. So when you're like 5, 6, 7, then we can go to, if they're older.
And that's scary too, putting your child under, right? And
Well,
so there's just a lot of
just give them a little local,
Yeah.
but yeah,
Okay,
they're awake,
gotcha.
and then they could see stuff coming, and it's a whole behavioral issues. Then
Yeah, absolutely. So with talking about the release, so my kiddo's going to get released. What does that process look like? Emily, how long are they in your office? And then you can tag in with what the procedure specifically is involving, like lasers and stuff like that. I think you touched on it a little bit earlier, but kind of fill in the blanks with walk a parent through start to finish.
Yeah, so they'll come in for an evaluation. We really, really love to see families before they go for a release because it gives us a good baseline. And it also makes us ensure that we have good feeding options for them. Just because even if you're breastfeeding maybe not well or even not too bad, you can go for a release and then the feeding process can regress a little bit. So it might mean like looking at another option to get them on a bottle or something so we have options to make sure that things don't go south. So they'll come in, we'll do an evaluation, and at that point, therapy is usually weekly until they go for the release. We prepare the family and show them how to do the wound care management, getting them in the mouth to do exercises on our end so that the family feels really confident in being in the mouth without the wound care. And
It was
then
intimidating.
It is.
It really is.
It is. And making sure that they're prepared for that. And then we'll often explain to them, like, just like how you guys, like, you'll go back, she'll assess baby, and then the baby will go for about 10 minutes. So we explain this process to the families so that they can know a little bit before they go. Then they'll go for the release. We like to see families 24 hours post-op at least. So we can make sure feeding's going off without a hitch, support family if we've got emotions running, crazy, and just reassure families. Because a lot of times they're like, am I doing the stretches right? Are we reattaching, and we can kind of walk them through that and give them some reassurance. And then therapy really doesn't look much different before or after. It's just a continuation until we see those symptoms have gone away. And then they're off to the races. So in a pretty streamlined, simple case, most babies are with us like maybe 4 to 8 sessions total.
And that's over what period of time? Because the exercises are recommended for, that's another point of topic too, though, those post-exercises. What is your opinion on how long the exercises should still be going on?
I like 3 weeks for the lip and 6 weeks for their tongue.
And then Emily? Similar,
I would
different?
agree with that. I've had other providers where families have maybe chosen to go to a different provider and they're like, oh, just do it 2 weeks, 3 weeks. That does not, from a functional standpoint, I see reattachment. I also find 2 to 3 weeks post-op is when that wound really wants to contract, especially with the tongue. It just wants to just hone in. And that's when I feel like we really got to be at work. Those first couple of weeks are important, but that third week and beyond, we're maybe adjusting, like doing more massage in the mouth at the new frenulum. But I think if we're stopping, we're like playing with fire, but on that. So
Well, and muscle is memory, right? I had one provider tell me that these ties can start as early as 12 weeks in utero.
yeah,
So let's assume a 40-week pregnancy. That's 28 weeks that your mouth has created these patterns
exactly.
and memory, and 2 weeks isn't going to unwind that.
No, I
Right.
mean, yeah,
2 weeks of post-care is not going to unwind that. But even 6 weeks, I'm not confident solely that the body is completely rewired to where, it's a complete relearning
Yeah.
process. Not all of my daughter's symptoms went away right away. I mean, some took 6+ months, and to each their own. Given the appropriate therapies, it allows it to heal a little bit faster, but there's no way to, I think there's instant gratification, and people are like, well, she's not latching, or, oh, they're still refluxy. It's
Yeah.
going to take time.
right.
It's going to take time.
I just want to add too, just because it looks healed and closed up doesn't mean it's done.
Yeah.
There's still a lot of collagen and everything reorganizing underneath there that you got to worry about.
Yeah, and I think that's really important for listeners to understand and that goes with everything in the body, right? I mean,
Right.
this is what we're talking about today, but it does take a while to retrain, and assuming that it's getting retrained in the proper way too, but that memory fixation is really, really hard. So that's a good point you made up about the time where it does try to really contract and come back.
I see that across the board. It's even for older patients who have gone and had a deeper release. Maybe they've had general anesthesia and gone under and had a deeper release. It's the same for them. And then the other thing that we like to watch for on our end, then I'll check in with Dr. B, is scar tissue, because that can come up a little bit later. And we have ways that we can support families through that to kind of get rid of that scar tissue, so that, because that scar tissue is going to take away from those functional things, like the extension and how high that tongue can reach up to the palate. And we don't want that. We want that scar tissue to stay away. And so monitoring that through that process is really helpful too, so they can get that most out of that release.
Yeah. So then kind of closing up on that, Dr. B, lasers. What's your post-care in the office look like? Breastfeeding and arnica was what I was suggested, or Tylenol. We didn't go that route, but what does that look like for initially post-revision?
Sure. So as soon as I'm done, I take the baby and give them back to mom and dad. And we have a nice recliner that they can just sit and hang out. And sometimes babies will latch right away. Sometimes they're just upset and uncomfortable and they don't want any part of that. Most of them do, but not all. And then they can start stretches later that night. And I say at least 4 good quality ones a day. I would like 6, but I know in a perfect world, sometimes, mom's going back to work. She can't just leave work and do some stretches. And, grandmas don't want to do that.
Yeah. What type of, do you use arnica? What are your suggestions as far as pain options?
Sure. So I like infant Tylenol if they're younger than 6 months, infant Motrin, older than 6 months for the first day, maybe day 2. We also arnica for sure, especially before stretches. That helps a lot too.
And for people that don't know what arnica is, it's a homeopathy, anti-inflammatory, helps with pain mediation. And so good tool for lots of different things. And then being on the boob.
Yeah.
Being on the boob. And so, it really, and I've told my patients that have gone through this process, she didn't seem to care. She wasn't really thrown off of her schedule by any means. What was so neat about our release, when she went in, she was tight. She's very tight. Her dad's tight too. So I said, it's a daddy.
It's always the
daddy
dad
thing.
Yeah.
But when she went in for her revision, I've seen her face for the last 3 or 4 weeks, just staring at it. And when she came back, everything had dropped.
It's crazy.
It was so wild to see. And maybe not everyone's is that dramatic, but now I have patients that are like, no, I'm looking pre and post to see, if there's changes. But I mean, the fact that something can be so tight orally and truly just hold your face into a position that we assumed was natural, that isn't, is just a real testament to what releasing those tissues can affect.
So I had one baby. He had the thickest lip tie I've ever seen in my life. I released it, fell right asleep.
Wow.
And you're like, that doesn't typically happen, but he was just so tight for the last however many months of his life that I released it, and it relaxed him.
Yeah.
And I'm like, he woke up when I started doing the tongue, but
No, undoubtedly. So, and then you use a laser, you said?
I do. I use a CO2 laser. There's a lot of different types of lasers out there. I like the CO2 laser. It also coagulates when I lace the tissue, whereas some of the other lasers, they, kind of just burn the tissue.
Yeah.
And those lasers also go slower. So mine, I can do a release, within, 30 seconds. And it's nice, clean incision. Usually no bleeding. It's beautiful.
Yeah.
There's also, they say less scar tissue when you do it that way, and better healing times.
Nice. And so for the more technical side of things, as far as cost goes, right? And so there are some providers that don't use insurance. Some providers use insurance where there can, depending on the plan, be help with that. And it's not an inexpensive procedure, I know personally. And so with your office, is something that you utilize insurance for? Is it cash pay?
We do bill insurance. We can bill medical and dental. Dental's better reimbursement rates.
Yeah.
So we, we'll bill, we have them pay up front, and then we bill the insurance, and then we can reimburse,
Gotcha.
if they pay it later.
And then Emily, your services, cash pay? Do you use insurance?
We do accept insurance. Not all insurances, but we do have cash pay plans for people.
And then same thing with our office, not all insurances, but we do accept insurance and have cash pay options as well. Final thoughts? Anything that the parents must know out there?
I'm going to be biased on this, but I wouldn't take my baby for a release unless I saw or had a feeding provider on staff.
I agree.
I have had situations where I've had to ask a release provider to wait because I was afraid that if that baby went for a release, they would be heading to the hospital for a feeding tube. And so I think making sure that you have someone that you can check in with before you go is really, really important, because just because you go for a release does not mean it's going to get better.
Or be successful. Yeah.
It might be worse before it gets better. And you don't want to be fumbling through Google in the middle of the night trying to find someone that you can get into. And even if you call them, they might not have anything available right away. And so I think that's my biggest advice. We want to make sure, and you also want to make sure that that's actually the issue. That's actually ties. There could be other reasons, why, especially if you have a child with like a syndrome or something like that. Actually releasing a child with Down syndrome or another type of syndrome, it can make it worse. It can make their airway worse. And so just having someone on board that can take a look at those things before you go. And then also, like, if even if you have only a bottle-fed baby, making sure that we're looking at different types of bottles and things that we can do to make sure baby is getting a really solid amount of nutrition in, and we have a reliable source before we go. Because I would never want someone to go through a procedure and then be going to get an NG or a G-tube or something. So I think having that, having a team of people around you, I think is really important. Because it's not easy, but it can make a world of a difference when you do it right.
Agreed. Any final thoughts, Dr. B?
I would just say definitely it's multidisciplinary. I couldn't do what I do without you guys, and you couldn't probably do.
No.
Well, like you said,
Agreed.
you guys are not doing laser stuff.
Agreed.
So.
Nope. Not anytime soon.
Yeah, so it definitely takes a team, and it takes the right team too. There's a lot of, chiropractors, like you mentioned, that aren't trained in this, and there's also feeding therapists that, or speech pathologists that don't know that either. So,
Yep.
And dentists definitely for sure.
Yep.
A lot of great info today, so I appreciate you guys being here. And I think the take home is what Emily just said, is the team.
Yeah.
And someone that is versed in what we're trying to address, which is TOTS, the topic today, and that parents feel that they can talk to us, right? Ask questions and feel part of the care team, I think is really important too. It's our kids.
Yeah.
It's really important. And look, I get choked up.
Yeah, don't do that.
But anyway, it is. And it's just, I think this was great that we sat down and got some information out there. On the video, I'm going to tag all of our businesses. And so if any of the listeners have questions, they know how to get in touch with us. So
Yeah.
awesome, girls. I appreciate it.
Thanks for having us.
Absolutely.